In the treatment and management, it all depends on the stage and category of the disease. The first is lifestyle changes we want to advocate or we want to advise. So then we want to advise the bed rest in case of severe cases, not all. Then foot end elevation in patients who are having a pedal edema. And we want to advocate or we want to advise a salt restriction in these to try to decrease the extracellular fluid volume. And we have a drugs, diuretics that will eliminate sodium and water, or that enhances the excretion of these things so that the fluid volume is maintained. The ACE inhibitor, angiotensin converting enzyme inhibitors, or angiotensin 2 receptor blockers. These two work in the similar fashion. I will cover that. Beta blockers, very recently they have come up. Then cardiotonics, that is a digitalis, these are used. Then the treatment will be specific treatment, whatever may be the cause, that has to be treated so that you will be able to reverse back. Now coming back, what are the lifestyle changes? In the lifestyle changes, low sodium and low fat diet. The sodium causes fluid retention and increases BP. So it is better to restrict the sodium. Now low fat, because you want to adopt weight loss strategies. So that means low fat diet that will go for the adaptation of the weight loss. And the extra weight is a extra pressure and the extra metabolism, and it will be a strain on the heart. So you reduce the weight. So that is one of the strategies. Then in case if it is not severe, in case of the moderate degree of the heart failure, you can ask them to be physically active, not a rigorous exercise, but physically moving a morning walk or walking, and then trying to do the daily chorus and without any of these things. That exercise will help him to reduce the stress and trying to help him to maintain the blood pressure or trying to bring the pressure, and even the tone of the vessels and the heart will be maintained. So that means you advise the patients not to be sedentary. Let them participate in some activity. Then these things especially either reduce or eliminate alcohol and caffeine. The alcohol produces a myopathy, that means damages the heart muscle. The caffeine is a phosphodiesterase 4 inhibitor that increases the cardiac contractility. So it is the one is on the producing the contractile machinery, and this phosphodiesterase 4 inhibitor that increases the contractility. Both can weaken the heart, and they even in normal condition, and in a damaged heart they will worsen the situation. Then smoking is also enhances the because nicotine activates the sympathetic ganglion. It activates the ganglion, and the ganglion cells will increase the sympathetic activity. They will produce more damage to the blood vessels, and that again make the heart to beat faster and heart to beat strong, trying to beat stronger, because it cannot beat now. So these are the lifestyle changes you may want to advise to these patients. Now, coming back to ACE inhibitors and angiotensin receptor blockers in heart failure. So now, if I have seen the diagram here, so renin substrate angiotensinogen, and this is producing angiotensin 1 and angiotensin 2. I have already talked. ACE inhibitor acts here. That means that converts angiotensin 1 is converted to angiotensin 2 in the lungs and other vasculature. So now, if this is blocked, this is blocked here, no angiotensin 2 is formed. If there is no angiotensin 2, no vasoconstriction or no sympathetic activity and no aldosterone release. That is how it tries to protect. So now, if you are looking back here, the ACE inhibitors inhibit the formation of angiotensin 2. ARB block the AT1 receptors. AT1 receptors are here. Angiotensin 2, 1 receptors are here on the arrowheads there. They are there. And they block the AT1 receptors located on the blood vessels, sympathetic nervous system, and on the adrenal cortex and the heart. So they block it and they bring about the action. Now, AT1 receptors are G protein coupled receptors. So they are activating at a GQ and then at IP3 pathway. They increase the calcium content and stimulate the vascular smooth muscle contraction and the AT1 receptors. If you block the AT1 receptor blockades, so this contraction will not take place. So these ARBs, that means angiotensin 2 receptor blockers, have an advantage over ACE, that is the ACE inhibitors, because they will not produce, they will not increase the kinin levels. The kinins are vasodilators. They produce the vasodilatation, and again the kinins have a severe side effect. Side effect is they produce a cough and angioedema. So sometimes we have to drop it, the kinins, because of the kinins. The ACE inhibitors are becoming problematic. For that reason, ARBs or the angiotensin receptor blockers are involved. Now, looking at that, how they work, let me explain little more. Angiotensin receptor blockers in heart failure, they have the following physiological actions. I'm going one by one. They block the contractile action of angiotensin 2 on the vascular smooth muscle. That constriction is blocked. Hence, no constriction, that is dilated, the arteries and the veins. So that means the arteries are dilated, the resistance is decreased, afterload is decreased, veins are dilated, preload is decreased. Thus reduce blood pressure, preload and afterload conditions. So that means they are dilated, that means there is no increased pressure, that is the afterload. The veins are dilated, there is no venous return coming back, or venous return is diminished, so that means that is the preload. So that is what is happening. They block the effects of angiotensin 2 on sympathetic nerve. That means angiotensin 2 stimulates the sympathetic nerve for release and reuptake of norepinephrine. So that means they will block it. No sympathetic norepinephrine is not released. So that means if norepinephrine is not released, there is no constriction. That is another important aspect. Now, angiotensin 2 stimulates the aldosterone secretion from the adrenal cortex. So which in turn increases the renal excretion of sodium and water. So now by blocking this thing, there is no aldosterone. No aldosterone means no sodium and water. There is no water overload or increased extracellular fluid volume. That is how it helps. So that means it helps the heart to deal with whatever it has already. They inhibit the cardiac and vascular remodeling. So remodeling, I'm telling, remodeling is not a better word. So that means it will be going in a dimension in a bad shape. So they will prevent the cardiac and vascular remodeling associated with chronic hypertension, heart failure, and myocardial infarction. So by inhibiting so you will help this the angiotensin receptor blockers. ARBs are used in the treatment of hypertension, heart failure, and as indicated for the ACE inhibitors. So this is one of the drug. Valsartan is one of the drug. There are many other drugs or analogs are coming up. So they block the contractile action, reduce preload and afterload. They block the sympathetic activity. They block the aldosterone activity. They will inhibit the remodeling. These are the four mechanisms how ARBs work in heart failure. Now, how about beta blockers? So now, if we are looking at the beta blockers, so what they do, how they help the cardiac failure patients, in which they will try to decrease the heart rate. They will try to decrease the ventricular contractility, because if you are seeing it, this is the rate here. They decrease the heart rate here. They decrease the force here. Thus they will decrease the preload and afterload. That is how they work. So now recently, that means beta blockers have come. Previously, the beta blockers were not prescribed. Nowadays, the beta blockers they produce effective treatment of the cardiac failure. Now, this was the drug which was used earlier. Now also it is used, but the beta blockers and ARBs have taken up. So now how the digitalis work? Digitalis is a drug, it's an alkaloid, and this will produce positive ionotropic, and it is producing the inhibition conduction inhibition, so that it improves. Let me read this thing by because digitalis blocks this sodium potassium ATPase pump. This is where it blocks the sodium potassium ATPase pump. If this is blocked, what is happening? The sodium levels increase. If the sodium levels are increased, there is what is called a sodium calcium exchanger. Now, for the sodium exchange, there is one calcium coming back. So that means the sodium levels inside are increasing. So now they cannot be held up. This exchanger is activated, and now in exchange of sodium, calcium enters in. Once the calcium enters in, calcium in the cytoplasm increases the TNC, that troponin C, and increases the calcium binding, increases the contractility. That is how this is working. So if you are looking at the myocardial contractility, this increases the ionotropy. So that means thereby reversibly inhibiting the myocardial sodium potassium ATPase pump, thus increases the intracellular calcium, and via the sodium calcium exchanger mechanism, that is the thing happening. This increases the cardiac contractility. It blocks the digoxin, or digitalis blocks the conduction. So that means AV node, that means it decreases the heart rate, because the heart rate is beating very fast, so that slows down. So that is one of the effect which tries to lower the heart rate. Then alteration in the cardiac. So it also changes the alteration in the cardiac action potential. The rise in the calcium levels lead to the prolongation of the phase 4 and phase 0 of the cardiac action potential. You have the phase 0 here, and then you come back here, then this phase 4. So that means the phase 4 in phase 0 are prolonged, so that thus increase the refractory period of the AV node. Once the refractory period of this conduction system is there, so it slows down the heart. It slows down the heart, and that decreases the whatever the arrhythmias created. So that means it tries to control the heartbeat in normal. That is how the digitalis works. I want to see the increased calcium level because of the sodium calcium exchanger system. That's one point you want to tell. The second thing is blockade of the conduction, and the prolongation of the refractory period. These are the three things you want to tell about digitalis. Okay, so now in conclusion, I want to conclude what happens, the heart failure. So now let me start with the lungs here. There is a pulmonary dysfunction, pulmonary edema, pulmonary congestion, and hypoxemia that will again produce the dysfunction, that will enhance the dysfunction. Now what happens to the muscle? The muscle ischemia produces, and the weakness and tiredness and fatigue, and that will decrease the venous return, and because it is not again increases the cardiac dysfunction. It will produce anemia because of the hypoxemic effect, and that will again have the load on the heart. So that means anemia produces the preload, increases the preload, and it will have a renal dysfunction, which will produce the renin angiotensin aldosterone system, and even the water excretion, the water elimination, that also is being hampered. So the endothelial neurohumoral imbalances, that means endothelin 1, nitric oxide, they are also imbalanced, that will further add to the cardiac dysfunction. The neurochemicals like autonomic nervous system activation, the brain ischemia, they are hampered. So all these things. And then we have the adrenal catecholamine release. So they are also hampered. All these things add up to the myocardial dysfunction. So that is what the heart failure is producing. Maybe one day it starts with the initial stage, then goes with a compensated stage, finally irreversible stage. It involves various systems, and is fatal and is progressive. Treatment is to prevent the predisposing factors and after effects to improve the cardiac function to provide improved circulation. That should be our aim. So this is in summary. I want to conclude with the heart failure. Now, these are some of the key words I want to read for you. Systolic failure, diastolic failure, ejection fraction, cardiac reserve, causes of heart failure that I have made the four things: the energy or engine or the tubes and valves and the external factors. Then paroxysmal nocturnal dyspnea. This is a very important for your examination point of view. Orthopnea, ascites in heart failure, hepatomegaly in heart failure, stages of heart failure, classification of heart failure. So then forward effects, I have mentioned about the forward effects. The damming effects I have mentioned about. The treatment strategies I have given. ACE inhibitors and angiotensin receptor blockers. Then beta blockers, diuretics, digitalis, and the various symptoms of the heart failure, signs of heart failure, and many more things you can try to think about. These are the reference books, and the main thing I have taken it from Jackson and his colleagues, associates from the British Medical Journal, ABC of Heart Failure. That is where I have taken some of these things, and the guidance textbook or Best and Taylor's textbooks. Thank you.